Welcome to this month's basic training video. This presentation will focus on lower extremity fracture management techniques and best practices. Identification, stabilization, and rapid treatment of any fracture is a fundamental skill for all EMS providers, no matter the level of certification or licensure. Prompt, efficient application of these assessment and management skills without causing further damage can greatly improve chances for a positive patient outcome and return to their best functional ability. So why do we splint in the first place? When do we need a splint? What do we gain from splinting? And is there any real therapeutic value? The body's defense to further injury after it's occurred is to create swelling and pain at the site of injury. The swelling creates a sort of splint, reducing the movement at the injury site, while the pain is to remind us not to move it. It is this understanding of how our bodies work that has led human medicine throughout the ages to accept that splinting is helpful and, when done correctly, can save a life and functional use of an injured limb. Let's look at a few pages in the fracture management playbook. Once an injury is located, it should be stabilized manually on both sides of the injury. Any angulated fracture should be attempted to be placed in a position of function unless you meet resistance or increase in pain is caused. Consider calling ALS for pain management early in the incident. Always remember the credo, life over limb. When using rigid splints, care should be taken to pad all natural voids. Distal pulse, motor, and sensory assessments are done prior to attempting to straighten the injury and once stabilization or splinting is completed. Consider applying ice or cold packs to the injured site to reduce localized pain and swelling. When using cling to secure splints, use 6-inch for lower extremities and 3 or 4-inch for upper extremities. The following live model demonstrations depict the preferred method for application of the described splint. Scene safety concerns and BSI levels should be assumed met correctly per Maryland protocol and local SOP. In all the live model demonstrations, the extremity used shall be considered assessed for applicable signs and symptoms of injury and should be considered positive for the need to apply the demonstrated splint. In cases where a fracture would be considered open, please remember proper management techniques to include application of sterile dressings over the wound using aseptic techniques. We do not flush open wounds. Our goal is not to introduce more contaminants into the wound that is already complicated. Finally, what about pain management? This one is purely dependent on your patient's ability to tolerate the repositioning and the splint that you're applying. Each case is different and should be assessed with an eye towards making the patient as comfortable as possible. Remember, splinting can be painful, so let's plan ahead. Enough already. Let's get started. The foot and ankle splint, using the traditional method. The stabilizer will calmly assume firm but gentle stabilization of the injured body part from the patient, who might be holding the injury in a supportive manner. The stabilizer is now committed to this support throughout the entire splinting evolution. They're only relieved by completion of the appropriate splint method. The splinter assesses pulse motor and sensory function distal to the injury in order to establish a baseline for function. Take this moment to consider pain management to include application of a simple cold pack. Draw the pillow to both sides of the injury in a sandwich type motion. The stabilizer will readjust their grip to include the pillow. This new grip allows the stabilizer to assist in lifting the injury, thus helping the splinter to place the needed cravats beneath. The ankle hitch is placed first. Divide the cravat equally on both sides of the ankle. Pull up towards the patient's head and cross the free ends behind the ankle pillow combination. Now take each side and bring forward to cross in front of the lower shin. Now here's the trick. Take the free ends, bring them down towards you, placing the tag ends under the cravat, just below where the ankles would be located. The compression of this injury is gained by pulling these ends laterally first, then up while keeping tension, and tying the remainder in front across the lower shin. Now another cravat is used to tie the remaining open end of the pillow. This secures the system. A final check of pulse, motor, and sensory function is made and recorded. The tib-fib, straight knee, or distal femur splint. The stabilizer will calmly assume firm but gentle stabilization of the injured body part from the patient. The stabilizer moves the injured extremity into a raised position and maintains this position while the splinter places the appropriate length board splint beneath the injured leg with the padding towards the patient. Now the stabilizer can incorporate the board into their grip while the splinter takes the time to pad the voids under the injured leg. The stabilizer is now committed to this support throughout the entire splinting evolution. They're only relieved by completion of the appropriate splint method. Now for the ankle hitch. Divide the cravat equally on both sides of the ankle. Pull up towards the patient's head and cross the free ends behind the ankle board combination. Take each side now and bring forward to cross in front of the lower shin. Now here's the trick. Take those free ends, bring them down towards you, placing the tag ends under the cravat, just below where the ankles are located. The compression for this injury is gained by pulling these ends laterally first, then up while keeping tension, and tying the remainder in front across the lower shin. The area immobilized by the splint depends on the length of the board splint. Remember to choose an adequate length to support above and below the site of injury. Use enough 4-inch or 6-inch cling to wrap the injured leg from distal to proximal, beginning below the site of injury and finishing above the injury as shown. A final check of pulse, motor, and sensory function is made and recorded. The femur traction splint. In cases where a traction splint is considered, remember, they are only to be used for suspected midshaft femur fractures. The stabilizer calmly assumes firm but gentle stabilization of the injured body part from the patient, who might be holding the injury in a supportive manner. The splinter places the traction device ankle hitch around the ankle, ensuring the red tab end is at the patient's heel and that the stirrup is snug to the patient's foot. Next, the thigh strap is placed behind the knee and scissored up the leg to the groin where it is buckled and tightened. Make sure to place the receiving slots on the lateral aspect of the thigh at the pelvic crest and that the male genitalia are clear of the strap. Now measure the traction pole along the injured extremity, ensuring the hook ends extends one joint beyond the patient's natural heel. Insert the other ends into the traction pole receiving slots. Now wrap the yellow elastic knee strap tightly around the knee. Now the yellow loop of the ankle hitch is placed over the hook of the pole. Traction is applied as the splinter pulls the red tab down from the heel with one hand, while smoothly feeding slack through the buckle with the other hand in a controlled manner. The manufacturer states the tension should be approximately 10% of body weight to a maximum of about 15 pounds. Well, it's obvious we actually can't measure that, so our goal is either a noticeable reduction in pain from the patient or an equal length to the uninjured side. The green elastic ankle strap is wrapped snugly around the ankle, just below the calf. The red elastic thigh strap is then tightly wrapped around the thigh, as high as possible, above the site of injury. Notice that the stabilizer is maintaining their position and moves around the application of the red elastic thigh strap. Another check of pulse, motor, and sensory function is made for comparison and noted for any changes. The hip fracture dislocation traditional method using blanket and cravats. The stabilizer calmly assumes firm but gentle stabilization of the injured body part from the patient, who might be holding the injury in a supportive manner. The splinter prepares 4 cravats and enough blankets to pad the triangular void between the legs. Notice how the splinter passes the 4 cravats in the void space behind the patient's knees to reduce movement. 2 of these cravats are scissored down and 2 are scissored up the patient's legs and spaced equally. The narrowly folded blanket is measured along the patient's uninjured side, and again folded at the heel, as shown. This fold is what fills the triangular void between the patient's legs. The measured blanket is now lifted and placed between the patient's legs, starting at the crotch, paying special attention to filling the void between the legs. Notice how the splinter moves the uninjured leg to the injured side to further close the void between the legs while reducing movement on the injured side. While the stabilizer maintains their position, the crevettes are firmly tied in a proximal to distal fashion, using surgeon's knots placed 2 above the knees and 2 below the knees. The proximal to distal tying method is used in this case so as not to load the patient's hips with pressure laterally. The bottom fold of the blanket should fall just beyond the patient's heel. Keep in mind, when retightening the cravats, this should be done in the same proximal to distal order as initially performed. Remember to check pulse, motor, and sensory function before and after application of any splinting method. In this injury type, please be sure to note any rotation or shortening on the injured side. Record these findings in your report. Secure the patient to the scoop stretcher using spider straps or 9-foot straps, depending on what you have, before moving the patient to the EMS stretcher. Hip fracture or dislocation. Immobilizing them using the KED. The KED is placed under the patient using the preferred straddle slide method in order to minimize movement of the injured hip. It is placed inverted and centered to the patient's injured side with the straps away from the patient's body. Now the stabilizer can calmly assume firm but gentle stabilization of the injured body part from the patient, who might be holding the injury in a supported manner. The splinter now wraps the KED wings around the patient's pelvis and loosely connects these 3 straps. Once connected, the splinter tightens them using 2 hands in a controlled feed manner from distal to proximal. Now the splinter moves to the lower leg and draws the smaller wings of the KED around the leg in the calf area. This is secured with a cravat tied tightly with a surgeon's knot. The straps at the pelvis are then checked again and adjusted as needed for firm tension in the system. Remember to check pulse, motor, and sensory function before and after application of any splint for comparison. Make a note of this in your patient care report. The hip fracture patient now immobilized with either the blanket cravat or the KED method must be further managed by placing them on an orthopedic or scoop stretcher for movement to the EMS stretcher. Pelvic fracture or dislocation, immobilizing using the KED. The KED is placed under the patient using the preferred straddle slide method in order to minimize movement of the injured pelvis. It is inverted and centered to the patient's injured side, and the straps are placed away from the patient's body. In this application, remember to place the KED waist high to the patient, with the head wings just above the knee. The stabilizer calmly assumes firm but gentle stabilization of the injured pelvis from the patient. Now the splinter wraps the KED wings around the patient's pelvis and loosely connects the three straps. Notice the KED is placed higher on the pelvis to fully encompass the iliac wings. Once connected, the splinter tightens the straps using two hands in a controlled feed manner from distal to proximal. The straps at the pelvis are checked again and adjusted as needed for firm tension in the system. The splinter now moves to the leg and wraps the smaller wings of the KED around the leg in the thigh area. This is secured with a cravat tied tightly with a surgeon's knot. Remember to check pulse, motor, and sensory function before and after application of the splint for comparison. Note these findings in your report for any changes. Pelvic fracture or dislocation, immobilizing using a sheet or a lightweight blanket. The folded sheet or lightweight blanket is placed under the patient using the preferred straddle slide method in order to minimize movement of the injured pelvis. It is centered under the patient's buttocks equally, with both the stabilizer and the splinter taking up the free ends. The sheet or blanket ends are exchanged between the rescuers and drawn tightly across the pelvis. The free ends are twisted, like a twist tie, in front of the pelvis one revolution, and then back under the sheet or lightweight blanket to tie the ends in a bulky overhand knot. Care should be taken to ensure the knot is as tight as possible. This has the effect of stabilizing the injury through firm compression around the pelvis. Remember to check pulse, motor, and sensory function before and after application of any splint for comparison. Note these findings in your report for any changes. The patient now immobilized with either the KED or the blanket method must be further managed by placing and securing them to an orthopedic or scoop stretcher for movement to the EMS stretcher. The bent knee injury, one board method. The stabilizer will calmly assume firm but gentle stabilization of the injured body part from the patient, who is more than likely holding the injury in a supportive manner. A single padded board splint is preloaded with two cravats and passed in with the padded side towards the patient. It's placed on the patient's lateral side, above and below the site of injury, with the goal that the stabilizer will incorporate the single board splint seamlessly into their support of the injury. And while it's unusual to pad for voids placed in this fashion, your patient's body type or injury might require further padding.
The splinter identifies and pairs the cravat ends correctly and passes them behind the knee and forward to be tied on the outside of the splint. Care should be taken not to cross the cravats behind the leg. Rather, Guide them around in parallel. Because distal to proximal is preferred, we start with the calf. Tie the ends using a surgeon's knot, further drawing tension by including the base of the cravat as shown. Repeat these steps to capture the thigh. Notice the stabilizer maintains their position throughout, only moving slightly to allow tension to be applied to the system.
The patient now immobilized by application of this splint should be further managed by placing and securing them on an orthopedic or a scoop stretcher for movement to the EMS stretcher. Another check of pulse, motor, and sensory function is made for comparison and noted for any changes. The bent knee injury, using the two-board method. The stabilizer will calmly assume firm but gentle stabilization of the injured body part from the patient, who is more than likely holding the injury in a supportive manner. The padded board splints are preloaded with one cravat and passed in as a pair with the padding towards the patient, sandwiching the bent leg between them. The pair is tightly tied together with a cravat, and the surgeon's knot is placed on the lateral side of the splints. The stabilizer can now more easily incorporate these board splints seamlessly into their support of the injury by squeezing the boards together as shown. And while it's unusual to pad for voids placed in this fashion, your patient's body type or injury might require it, so be prepared. The splinter places a cravat centered behind the distal calf, drawing the ends forward, crossing over the pair of board splints, and again looping under in a figure-8 pattern, to be surgeon's knot tied on the outside of the lateral splint. The same steps are followed at the patient's proximal thigh. Remember, while the desire for a supportive fit is critical, please bear in mind that movement of the patient's injury will be met with increased pain response. The stabilizer has a lot to manage here, so consider splitting that effort by adding manpower to your incident. Another check of pulse, motor, and sensory function is made for comparison and noted for any changes. Thanks for taking some time to review lower extremity fracture management. We've seen some terrific demonstrations of the following management techniques: the foot and ankle splint, the tib-fib, straight knee, and distal femur splint, the bent knee using one board or two board splints, the mid-shaft femur traction splint, the hip fracture or dislocation using traditional and KED methods, the pelvis fracture or dislocation, also using traditional and the KED method. Always remember to complete any lower extremity splinting method by including plans for safe evacuation to the EMS stretcher. Orthopedic or scoop stretchers, spine boards, Stokes baskets, and even reeve stretchers can be used with appropriate lashing. Let's not forget the manpower. This minimizes the chances of further injury to the patient and our own fire rescue personnel. We appreciate your watching this month's MBT. We hope you gained in knowledge and now have a leg up in the future as you make safe and smart decisions managing lower extremity fractures. Another Hell's 56 Acres production.